Good afternoon, everyone. We're all welcome to today's discussion. We started in a matter of 2 to 3 minutes. So we can please send a link to our colleagues, friends, and loved ones who think would be of great help for today's discussion. And let's all finally take note of the Zoom etiquette. It's one of the so kindly mute your microphone. Send the speaker will be the one doing the talking. You can come on video if you want. Essentially, we humbly ask once you join or whilst in the meeting, just be checking from time to time if your microphone is muted so it doesn't disrupt the flow of the discussion. So once again, you're all welcome to this afternoon's discussion on the management of the aggressive patient. My name is Abuaji David, and I'll be your facilitator for today. So we'll start in a matter of a minute. So let's kindly share the link. If you happen to have any questions during the presentation, you can please write it down. We'll make time for the questions. Yes, so you might choose to unmute your mic during that time to speak, or you can just send your question to the chat box and the speaker will speak to it in future. So once again, we are all welcome. And I hope you can all hear me. Please, can we all hear me? Hello. Please, can I be heard? Think it's better now. Is the sound clear? All right. So once again, we're all welcome to Hope Exchange Medical Center Psychiatric Department. There's a meeting we normally organize from time to time. And for today's topic for discussion, our resource personnel will be speaking about the management of the aggressive patient. The management of the aggressive patient. And before we start, we would want to say a prayer. So we'll ask our doctor we'll ask one of our doctors in the house to say a prayer for us. So Dr. Yabwati will say a prayer and then we'll start.
Yeah. Thank you for this meeting. Thank you for this meeting. Father, we pray for this meeting into your hands. Father, we ask that you mention Father, we be here and understand whatever that was today. Father, we pray that you give us understanding and sound. We will speak and Father, may you speak to us. This month.
Amen. Amen. Thank you so much, Dr. Watson. Thank you. Thank you. So without wasting much time, we're going to go straight into the purpose for this meeting. And I would just like to share a few words on why we're having this meeting. Why is there the need to discuss the management of the aggressive patients? So the hospital environment is a high pressure zone coupled with people with diverse backgrounds, including hospital staff. patients and their relatives or acquaintances. Violence and aggressive behaviors, if not properly identified and managed holistically, can worsen the work environment and indeed service delivery and adverse mental and physical health outcomes for both the staff and patients or the relatives. This webinar will address some of the definitions, the factors, etiology, and ethical management approaches. I believe we all should be ready for an exciting webinar this afternoon. And I'm sure by the time we're done with this webinar, we'll have a lot of take-homes that we'll be able to apply in our practice going forward. Thank you very much. Without wasting my time, we're going to take the presentation from the resource personnel, and I would like to give a bit of a profile introduction. So our resource personnel for this afternoon discussion is in the person of Dr. Bernard Ogundipe, who is a specialist psychiatrist. He's the HOD of the psychiatry department at Hope Exchange Medical Center in Kumasi. He is a member of the Ghana College of Physicians and Surgeons. His MBBS degree was obtained from a prestigious College of Medicine, University of Lagos in Nigeria. He also holds 2 diplomas in telemedicine from Howard University, Washington, D.C., and Virginia State University, Charlottesville, U.S. He's currently the organizing secretary of the Psychiatry Association of Ghana. He's also a family-oriented man, and his leisure activities include music, gardening, cooking, and internal journalism. Ladies and gentlemen, I would like to hand over to our resource personnel to take us through the discussion. Thank you.
Thank you, Dr. Boaji. Good afternoon to everyone. Hope I'm audible enough. Without much wasting time, this afternoon has been highlighted earlier on. We are looking at the ethical approach to management of an aggressive patient. My outlines include a brief introduction or definition of key terms, types of aggression, etiology, risk assessment, management and ethical considerations when you are tending to these situations, my conclusions and references. Okay, so aggressive and violent behavior is very common to settings like Dr. mentioned earlier, and simple agitation may not predictably progress to aggression and violence by any patient in hospital. So the behavior can manifest in different forms, start from just verbally abusing a staff member, which we see commonly in hospital environment, to verbal threats and intimidating physical behavior. So, according to WHO, violent behavior is any intentional use of physical force or power, okay, to threaten someone, either themselves, with deliberate self-harm, right, or to threaten another individual, or a group of people or properties, or a community that is eventually resulting in injuries, death, psychological harm and deprivation. And this definition, even though on face value may think it's simple, but it covers almost everything. If you all recall, in I think 2013, Kofanochi Desweba missing baby case, whereby a woman declared she lost the child and the family were agitating that they didn't see the body. So the whole community where the man resigned came to court, and there was a lot of physical and verbal aggression against all staff. Okay, so there's property damage to hospital property and everything. So this definition kind of captures that whole scenario and it can happen anywhere, right? So this is a standard WHO definition of violent behavior. And when it comes to aggression, it's an overt event, most often it's harmful, right? And it stems from our social interaction, whereby the intent is to inflict injury or cause other form of unpleasantness upon another individual. Okay, most times, maybe as a result of retaliation, the person is retaliating towards something, or it may happen without provocation. So aggression can occur in those instances. Now, when it comes to the workplace, aggression and violence from patients is the most common cause of workplace violence. What it means is, in some instances, the violence actually comes from your own colleague or staff, but the majority of the instances is stemming from the patient or their acquaintances or their relatives. And the emergency department and psychiatric department seems to have a lion's share of this event happening. Right? So, as doctors, nurses, and other clinical staff involved in patient care, adequate knowledge about this, how these things may happen, and how we manage aggressive patient, with the aim of mitigating or de-escalating the situation is very paramount. So, how common is this? Is it a common occurrence, or is it something that just comes out of nowhere? Okay. Now we have different kinds of patients presenting to the hospital. But there are some group of patients, especially those with mental health disorders, or those who have what we call substance use disorders, or people who have both substance use disorder with mental health disorders coexisting. These are the group of patients who have the highest incidence and prevalence of aggressive and violent behavior in the hospital setting. Now, verbal assault seems to be the predominant form of violence recorded by most health workers. Okay, and they also cross-sectional study across different countries. And in Australia, we had up to 58%, and in Brazil, it was 100% when it comes to verbal assault. So it means almost everybody in Brazil who work in the hospital is being exposed to one form of verbal assault or the other. And when it comes to the gender disparity, female health workers tend to bear the brunt of having verbal abuse compared to their male counterparts. Just last week, where the female was charged, I saw her, she was verbally abused, she was actually crying, all because a relative of the patient said some very unkind words to her. So these are common things that happen, and it shouldn't be something we assume that it's part of the work. We should never normalize it. Okay? So nurses are 3 times more likely to experience aggressive and violent behavior while performing their duties compared to the other cadres of hospital staff. Now, when it comes to physical assault, between 35 and 80% of healthcare workers have experienced this during their practice. I mean, during their working periods or their working times, about 35 to 80% of healthcare workers have experienced some form of physical assault. And when it comes to those who are perpetrating it, majority are males, about 63%. Okay, and 66 points, that's about 2/3 of workers have experienced one form of violent and aggressive behavior in their practice. When it comes to psychological assault, about 1/3 to 2/3 of healthcare workers have experienced this based on their geographical locations. Now, you want to ask yourself, why aggression? Does it serve any purpose? Okay. So, a lot of studies have been done from social sciences and all that. And it's been found that sometimes aggression could be a form of expressing anger or hostility. Right? It could also be a form of asserting dominance, or intimidating someone, or threatening someone. It also be a means of achieving a goal, okay, either a political goal, something has to do with poverty, like someone who's an program, okay, or expressing possession, responding to fear, reaction to pain among lots of others. So, what causes aggression? It's good to use the three-pronged approach to looking at all this because it allows psychosocial model of looking at the etiology of the cognitive factors. Using the psychosocial approach, this is not a new thing. A gentleman called Mendel in 1977 brought up this concept. And there's always a biological component to most things. And there's a psychological and social environmental factors to it. And so when you're looking at etiology, you're looking at the management, you're looking at the investigation and treatment, you should always use this approach. That way, you're looking at the patient in totality. So, what are the other factors that may cause aggression or violence? Hormones such as testosterone and cortisol, okay, and some neurotransmitters such as serotonin and dopamine have been linked to aggression. And when it comes to the brain, you have different parts of the brain that handle different components. The amygdala is involved in aggression, and of course, the frontotemporal areas of the brain all are involved in the biological etiology of aggression. When it comes to psychological and other mental health conditions, people who have a background mental health disorder or a background substance use disorder, a combination of these have a higher incidence of being violent or being aggressive compared to the general population who don't have that background. Some common mental health conditions include autism spectrum disorder, attention deficit hyperactivity disorder, bipolar affective disorder, schizophrenia or other psychotic conditions, conduct disorder in young people before the age of, before attaining the age of adulthood. And if they are adults, dissocial or antisocial personality. All these, they also have anger control issues, post-traumatic stress disorder. All these can make them prone to being either violent or being aggressive. Now, when it comes to the environment, most times we don't look at the environment as being a positive factor of violence. I will use the emergency for instance. Sometimes we go there, we have two air conditioners working, two air conditioners working, sometimes none is working, very hot. Sometimes overcrowded. Okay. And all these studies have shown that we expose a patient to be either violent or being aggressive. Right? Overcrowding can be a factor, a noisy environment can be a factor, foul smelling environment can be a factor. All the beeps, the patient monitors, ventilators working in the ER, all these are sorts of environmental factors that make patient prone to being violent or being aggressive. Okay, if the patient comes in and is intoxicated, it could be a factor or make them prone to being violent or being aggressive. Exposure to media violence, we watch movies that are violent, people shooting each other or stabbing each other. All this has a way of making the person prone to being aggressive. Or even witnessing aggression can also predispose that person to being violent. When it comes to some of the theories, mention what we call social learning theory, gentleman called Bandura, he does say exposure to violence in the younger age is big to think that it's not like before you start believing that or you think it's normal thing. I mentioned temperature being a factor when it comes to one of the factors of violence. And the records from the police forces shows that most violent activities happen during the summer season when the environment is hot probably the probably the other like winter period whereby the temperature is lower. So basically that and those alcohol intoxication is also a very significant risk factor for being prone to either violent or aggressive behavior. Okay. The media exposure, I think I've mentioned this. This slide also shows all those things we just mentioned earlier. So in the hospital setting, normally, there are some causes of, there are some disease conditions that they put the patient to being aggressive or being violent. So you can look at psychiatric conditions like mentioned earlier on. You can look at some psychological factors where they have a high level of impulsivity, all that. Poor tolerance, maladaptive coping skills. When we say maladaptive coping skills, it means when the patient is confronted with a stressor, the conscious manner in which they deal with it is not something that is desired. So, for instance, if you are faced with a challenge and try to look at the situation, address it, and look for solution, you can either decide to let me go and break it away. If I take alcohol, I'll forget that. So that's the maladaptive coping mechanism. Without that. So also we've seen so many times whereby on the ward, the patient is okay, stable, and within a short while is agitated. Sensorial level is going down. Okay, it's acutely confused and all that. Sure, we are looking at the delirium picture. So we can have this on the wall, we have an emergency at the post the surgical recovery room and all that. So this can also happen. So normal medical conditions, you're on the ward and before you know it, delirium like picture present. And you can have all this. There are sometimes like mentioned earlier, metabolic issues and all that. Sometimes the patient may be having withdrawal from alcohol or substance. It happens most times whereby maybe this gentleman or woman normally have a bigger dose of alcohol and he was hit by a motorbike in the hospital, he doesn't have access to go and take the visual thoughts of application. So if here within 12 to 24 hours, this man is sweating, agitated, being violent, probably is having a more withdrawal. So it can happen also. And in the labor world, in the opposite line department, complications of labor and delivery and all that are also prone to this violent aggressive behavior. Of course, the speed in which they come and call the side department is always when human start behaving just after the I believe after this presentation, we will have better insight on how. Now, I wouldn't go into the theories of aggression. I wouldn't go into that. But I just listed it so that you can, at your own different time, decide to read and read we have the biological theory, the psychodynamic theory, and the learning theory, cognitive theory, and the social theory by Albert Bandura, as mentioned earlier. These are things you can just go through to have a better insight into why some people may be prone to being violent and aggressive. Now, when it comes to the types of aggression, you can classify them as being passive or active. Okay, then to also be passive or instrumental, and the different synonyms for impulsive aggression, expressive aggression, affective aggression, reactive aggression. So when you are reading around this, you come across some of these terms with the same thing you are describing. Then we have the instrumental aggression or predatory aggression. The common one that easily comes to mind is someone who is trying to actually come to, let's say, okay, because he wants something. So it's planned most times. But the impulsive one, let's say you are driving and someone just cut across and you just become so annoyed, you feel like bashing the person and all that. So that's the impulsive aggression. So in that one, you usually don't have. You are there, oh, something happens and you are reacting to it. Now, I think I've mentioned it. So for the active aggression, it's obvious. You can see this person and he's coming to you with the probably the fist clenched, is stopping towards you with voice raised. You can actually imagine as if it was a cartoon you were watching, you probably see things coming from the nostrils and the ears. So that's active aggression. The effect is something you can easily see. Is in the open and it's not hidden. But the passive one is an indirect way. And the passive one, an example is you doing some, doing something where your behavior is different. So, like a slap in the back. So he's laughing at you, talking, but this same person is probably slandering you or spreading rumors about the Bible. Okay, so that is a form of passive aggression. So when it comes to the consulting room or the ER, and this person leaves and says, oh, let's never power. This is what he did. And you have no idea. So that's a form of passive aggression. Okay. So for the most part, says there are behaviors that are driven by feelings of anger or hostility. Okay, and the primary aim is to harm this person. Not that you want to gain anything, you don't want to harm or cause discomfort, either physically or psychologically to that person. As compared to the instrumental aggression, whereby there is, shall I say, a goal-directed agenda. Either you are going to rob somebody or you have a political agenda and you want to disrupt something. So it's planned. It's not something that is possible. Okay, that's the instrumental aggression. And I think I've mentioned different types of examples. Okay. Now, when it comes to gender differences, male and female, are there differences when it comes to how we express aggression? So, remember we mentioned the biological factors of testosterone and everything, and you know when it happens. So, males, when it happens, there's this hormonal response called the fight or flight syndrome. Either you fight when you're in danger or stress, or you run away. Okay, but for the females, they tend to do what they tend to friend a syndrome. Okay, they take a cool approach, and both of them is a response to a stressful event. Okay, but based on hormone levels of the male and female, tend to react differently. Now, almost and so on. Violent or aggressive, all these environments will dispose them to doing those things. Okay, crowding, there's a phenomenon called the mob mentality. I'm sure you've seen when you're watching a movie and they don't go into war, paint their faces flat. Alright? When they do that, they are de-individualizing themselves. So it's no longer them doing the stuff. It's a good doing it. Okay, remember what happened in the Rwanda during the Civil War? Okay, so it's a group. The Tutsis versus the Tutsis. You don't know that individual. So in that moment, you tend to do a lot, tend to commit a lot of atrocities because you know you. So it's a psychological phenomenon. So in a crowd like this inhibited, there's big degradation, there's big polarization. Right? So I will go back to this river example I gave. The river from the particular, I don't want to mention the area in case by being mentioned that they all came from that area, came to cats and destroyed properties, beat up doctors and cases and all that. It was a mob action. So that can also cause so those are the environmental effects, not connected. Those are the environmental effects of mental effects on when it comes to aggression, violent behaviors. So at the hospital, is it everyone that is violent or is it everyone that is aggressive? How do you assess that risk? This part is very necessary. This part is very necessary. Okay, you have to first of all identify the situations and know which patient or individual or group of individuals are likely to become more violent. Okay, and which situations will make the violence rate lower. It will help you as a clinician, as a doctor or nurse or member of staff who is working in an environment. Okay, so you help to find out what we call protective factors that will help you and techniques that will help you reduce the impact of any violent or aggressive behavior. That's to mitigate this. All right. Now, usually there are two methods we use in classifying and in assessing risk of violence. Okay. There's one that we use in the clinical setting. That's the structured professional judgment. That's what we usually use in the clinical setting. Then in the legal setting, there's something called the actuarial or statistical methods. But there's one particular example used as clinics within the hospital. For example, it's called SAP, SAAP. Memory. Those are the things you look out for when you're assessing the risk of violence. Then when it comes to the structured professional judgment, the very common one for those who are in the mental health space is the historical clinical risk 20, HCR 20. So that one is a structured professional judgment. Now, the actual statistical method one, that one, you are taking a decision that is devoid of your own preferences. Okay, so it's a little bit structured, right? And most times it's used in the legal setting. The patient, someone who has offended, who has committed maybe a violent crime or sexual crime, we want to know whether this man can go home on probation or not. What are the risks that he's going to commit that violence again, that violent act again? All right, so those are things they use to assess the risk. So the actual ones are structured, okay? They have what we call risk and protective factors, and they estimate the likelihood of future violence occurring again, okay, over a particular period. And like I mentioned, it's useful in legal settings. So human judgment biases are removed from the clinical decision making, right? And these are examples. LSI is the level of service inventory, the 52 item, I think 54 item inventory, okay? Then the static 99, then the stamp. The stamp on, I think we could easily use it at the emergency, at the ward, and then because it just, you're looking at different 5 criteria. The S is the staring. The patient is staring at you, okay? And the T is the tone of voice or volume, okay? And is this person agitated or anxious? Is he mumbling, okay, or pacing? That's the P. If we have any of these, then there'll be a higher likelihood of this patient being violent or aggressive. So while you are assessing your patient and you see any of it, you become more proactive in anticipating and mitigating the risk of violence or aggression. So this is the LSI. I just put it there so that you have an idea. We don't use this in the clinical setting, but you have an idea of tools that we can use. And I said it's a 54 item showing so many factors: criminal history, education, employment, their finances, their marital status, accommodation, leisure, companions, drug use, emotional or personal and attitude orientation. So it's like if you are taking the history of a patient, and all these factors can tell you likelihood that this person may be prone to violence or not. But we hardly use that. And this is just a snapshot of the LSI. Now, when it comes to the stamp, I mentioned earlier on is staring and eye contact, that's the S. Then the tone and volume of voice. Is this person anxious or agitated? Is person mumbling? Is person pacing? The more of this we have, the likelihood, the higher the likelihood that this patient may be prone to violence or aggression. So all of us can use this at the ER, irrespective of your kid. It doesn't really require so much mental brain power to assess. You don't really have to have any book to put this in your mind. So I won't talk about the static 99. It's also another risk assessment method. It also has both protective factors and risk factors. And also it also tells about the previous event whereby this patient was probably aggressive and what were happening around that time. So you have to also plan to prevent that. So for the SPJs, HCR 20 is a common one we use, okay? And he also mentions certain criteria, okay? The historical part is what has happened in the past when it comes to the patient, okay? So examples of structural covenant domain is the HCR 20, the psychopathology checklist, okay, the revised edition, and the survey, which is the structural assessment of violence risk in youth. But in the clinic, we usually use the HCR 20. At least I've been exposed to that, right? But all of these, you can actually use them to assess risk in the hospital setting. So these are an example of the HCR. So there's 10 components that has to do with the past event, what has happened. Then as this patient is presenting right at the ER or at the ward or at the emergency, whatever they are, what is their clinical state? What are you seeing right now in the patient? That's your clinical, right? Then the risk management in the future, all right? Your plans, do they lack feasibility? Are there other factors that will make this person relapse or be prone to violence, all right? Is this person non-compliant? Is there family support? Is he living alone? Does he have source of social support and all that? What are the stresses this patient is exposed to? So the HCR would look at this 10 components on the historical, 5 on the present, and 5 on the risk. It's a 20-item risk assessment tool. Okay. So I think we mentioned all this, and I'll use this as an example. So a patient comes to the ER. Maybe you've heard that the mental health service user is coming to the psych clinic, and the last time he was aggressive, he came to the ER. He was verbally aggressive, abusive, and all that. And the reason why it happened was he wasn't taking his medication, right? And he lives alone. So this is a history you pick. So when you are planning your management, you know that, okay, this man is here again. The last time he came, he was aggressive. But the reason why he wasn't taking his medication. There was nobody living with him. So what do? If you stop at just giving him his medication and you don't address who would monitor whether he's compliant at home or not, then there's a higher risk of him coming back again, or that day will still be aggressive. So you want to look at the social and psychological component. Who is going to stay with? Is there any relationship around? If there's no relative around, it's just one who can make sure every day he takes medication, who can make sure that every day he has enough medications on him. So these are the approaches you use when you use this risk assessment and how you handle it. Okay. So this survey is similar to the HCR. Won't dwell much on it. I want us to spend more time on the management and ethical considerations when it comes to how we manage our patients. Okay. Now, people have heard this saying so many times that it's part of the job. It's normal. It's okay. If you're a health worker, you should expect this. If anyone tells you this, please tell them it's never okay to tolerate violence and aggression at the workplace. Okay? It's never part of the job. There are things we can do to mitigate this risk, right? So it's part of the job. Don't accept that. That's why I started with it's never okay. And in the picture, you see someone being verbally abusive or aggressive to patients, even saliva coming out of the mouth and all that. And these are things we see. I remember when I started my residency in psychiatry, almost everyone I know, I tell them, oh, I'm doing psychiatry. Oh, so that's the next statement. Be careful. No. So it's never okay to be violent or be aggressive at the workplace. Now, the beauty of this presentation is I want us to move our mind from how traditionally we manage aggressive patients. Most time our approach is the patient is in front of us and is either violent or is aggressive. Okay, but we are going to use what we call the Hayden matrix, okay, in planning how to manage and reduce the risk of aggression in our patient. Okay, the Hayden matrix is simple, just a 4x3 column. So there's 4x3 table, 4 columns and 3 rows. Okay, and we'll divide it into before the patient came. Those are the 3 events when the patient. The role of the nurse, doctor, or the hospital. You look at the role of the patient, okay? Then you look at the social environment. What are the things that can predispose or mitigate the risk of violence or aggression? So the Hayden matrix and planning is not only to medicine, is related to natural disaster prevention, RTAs and all that, and you can always apply. So I believe at the end of this presentation, you can all go back to your respective hospitals or units and draw a Hayden plan. It's just 3x4, 4 columns, 3 rows, and you look at how this applies. So this is an example I'm putting on the screen. So there are 4 columns, like I said. The first column is the staff member or employee, all right? And the second column is the aggressive patient or their visitor or their relatives. The third column has to do with the physical environmental factors. And the fourth column is socioeconomic or social factors. Then when you look at the row, the pre-event, before this patient came, okay, what are the things we should do? One of these is education and training, like we are doing right now, all right? Then awareness, which is part of what we are doing now. Then resilience is when ability to bounce back from any adverse situation. All these are things we have to learn now. Then situational communication and de-escalation, right? If I will always use the ER because it's always a hot zone. That the ER and within the same team, there's an argument going on. That's almost like a recipe for violence or aggression. Okay, so all this will help. Situational awareness. A patient is mumbling, on his mental state appearance is disheveled and all that. He's mumbling, he's agitated, he's staring at you, and you turn your back on that patient. It means you're not aware of the situation, or the relatives are agitating, and you have maybe, it doesn't have to be the nurse or the doctor, it could even be the orderly who is about to clean the floor, and he has his earpiece in his ears, mopping the floor. He's not aware of what is going on. So it could be a target for the agitated patient. All right. Advanced risk assessment is what we just mentioned. Then advanced warning assessment. I don't think it's Angie is here at the ER, and I think the in charge is here. Do you have any alarm systems in the ER? Okay, so the aim is at the end of this presentation, you look at those things so that if you are in danger, what do you do? Elsewhere, you have personal alarm and there's a word alarm and there's a code. So when you mention that code, everybody knows this is what's going on, everybody will rally. So you don't have that system if for any reason Angie cannot shout, then we'll fail her in the course of the duty, right? So the pre-event is all what we are doing, and remove our potential weapons. It's amazing because my background was psychiatry. I come in, I see this season they used to cut the gauze. I tell you, okay, you guys should move to this side. Or what they used to break the vials for the injections. Or you see that surgical blade they used to cut. You see everything lying around. You see needles. I think 2 weeks ago I was discussing with Angie that even the drug cabinet, the patient should not have direct visual of that drug cabinet. We mentioned all this, so it's to prevent all this. So these are the pre-events. You as a staff, these are the things you do to handle aggression before the patient comes in. When it comes to the patient themselves and their visitors, one common one is a patient has so many visitors around them at the emergency. I'm using Hope Exchange emergency room as an example because we're all here. It's not a very big place, and there are explicit visiting time rating, but there's nothing about number of visitors. So you have one patient, he has 10 visitors, and you are complaining that mood also. And they will tell, what do you mean? Is it not visiting time? So you have to have clear communication. At this place, we don't tolerate violence or verbal abuse. Each patient is allowed 1 or 2, and it's posted right on the wall at the entrance of the hospital. So everybody is aware of this. And when they come in, they see, then it makes it easier. But if you don't have all these little things, it could be a source of aggression, okay, conflict, and if you are not careful, all kinds of things may happen. So when it comes to the patient, these are the things they should be aware of. If you don't do that in the hospital, it will be a problem. Then the physical structure, when it comes to the environmental, how is our A&E? When it comes to the access, there's something called egress access. Luckily, we have 2 access at the emergency. Thank God for that. Going in and going out, there are 2 access, all right? So there are some places the access is just 1. So if there's a problem, you won't have an easy way of moving. I'm using a temporary place at the hospital for my department, and we are here to get a permanent one. I was told recently that they've gotten a place where I can use, so I should come and inspect. I went down there. The first thing I noticed, I said, no, I just started shaking my head. Doctor, I want to pay Hanum. I said, well, there's only one access to this place. Very narrow corridor, no exit. Structural wise, it doesn't favor psychiatric department. I'm here to move. I'm dragging my feet. And I was trying to make some modification, but it's a little bit difficult, but the physical structure of the place, access, lighting, okay, good lighting, all right, shouldn't be crowded, should smell nice, okay, all right. Now, visibility, there's something called camera visibility and security man visibility. I think, remember in Ghana, there was a time the police were doing about visibility, whereby you see them at different places and you know there are police around, okay. Here, there are cameras around, fine. So that's one visibility. But do you have security men just in front of the ER? No. Is there any policeman here? No. So we have to act on that. There should be visibility both of camera, security personnel, and police, okay? Then when you keep your valuables, it shouldn't be
accessible to everybody. Okay, the reason why, in fact, one of the reasons why the cameras were fixed initially was there are a lot of theft. People come in, steal phones and all kinds of things, bags and everything. So where you keep your valuables and everything shouldn't be that accessible to everybody. Okay, and I mentioned egress accessibility. All right. Then use of safety glass. If you go to some place, you see where the nurses are. The nursing station is a little bit elevated, and the patient cannot easily reach across. It's all part of the security measures. And some of them, you see this safety glass and the nurses behind it. You don't have to have a bulletproof safety glass, but there's something called acrylic or laminated glass, whereby it can easily shatter. If someone hits it, it can shatter and injure you and all that. All these are considerations when it comes to the environmental, physical factors. Then, when it comes to socio-economic and social factors, the community awareness. We do community engagement. You go to a prayer, you go to place. They know you are here. They know this facility is part of them, right? They don't feel alien. They believe it's their own. So if you don't have that community engagement, they may think, any slightly, you see the community mobilizing to come to the hospital to cause disruption and all that. So these are all things you look at when it comes to pre-event. Now, during the event, let's say this patient has not come to the hospital, the patient or the relative or friends are being disruptive and all that. What do? I mentioned alarm system. You don't have it. How do you de-escalate? It's not fire for fire. You know, there's this football program whereby a journalist, I think it's Songo or something. Countryman Songo, yes. Fire for fire. At the hospital, aggression is not fire for fire, please. Okay, so you have to de-escalate. All right, so there's a slide on de-escalation that I added on how you go about it. All right, okay, and you have to also have the mechanism to ask for assistance, call for help. So at the end of today, I'm sure each department will have their own policies on how to do this, how to call for help, how to render assistance. Okay, then how to protect yourself and others. Now, when you're protecting yourself, you, the patient, the staff, there are other patients also in the ward. You have to also factor that in when you are handling the violent or aggressive patient, so that you don't expose patients who are already on the bed who can't really help themselves to the onslaught of this aggressive or violent patient. So that's during the event. Then, with regards to the patient, after you de-escalated, communicate. Normally, when you are de-escalating, let one person be the lead. Not so many people talking. Let one person be the one to communicate the information and everything, okay? Then have a way to initiate restraints of behavioral procedure protocols. How do you restrain a patient? I put up a slide on that, okay? I've seen some wonderful ways of restraining patients. To me, some of them look like torture. I don't know where they learn it from. Somehow, information is sent across to almost, I'm not against the nurses, but almost all the nurses know how to do that particular form of restraint. To me, I think it's torture. 2 weeks ago, or was it last week? There was a patient last week. There was a patient. I went to the ER, like, who did this? Please take it off. Okay, so we look at the proper way of doing physical restraint, the ethical way. All right. Then there's something called isolating the perpetrator from others. So if I can use an example of a relative who is being violent, not the patient. There are probably 5 relatives, and one particular one is the ringleader in quotes. To find a way to isolate or seclude that person from the rest. Okay, I don't end up having what we call mob action, mob mentality, whereby you can cajole the others. All right. Now, and sometimes you may have to actually prosecute, take them to court, call them to the police station. Someone beats a staff member up, destroys properties in the hospital. They follow the legal way. These are management protocols. I wish there were management members here, but someone should not just come to us to beat up. That's assault, right? Beat up staff, destroy hospital properties and you expect them to go away. No. So there should be a legal process also instituted. It should be a deterrent to all those who may think they may do all those things. Now, we don't have a special quiet room in the ER. We are looking for space. I'm looking at Angie in charge here. There's no space, but ideally you should have a seclusion area, okay, or a quiet place where we can take an agitated or violent person, either the relative or the patient themselves, to away from others. All right, that would be very appropriate, but we don't have that. So these are things we look at. Then we have a code-based system when it comes to the socioeconomic. So normally, code red, you all know code red is patient. What's code red? Angie. Code red, what's that? Critical matter, right? But is there any code for the violent or aggressive patient? None that you are aware of. So some places will have code white for a violent or aggressive patient. So when you code that, all your staff members know that there is a patient who is violent or who is aggressive. And you have a protocol. When you have that code, you know what to do. The same way you say code red, everybody knows what's going on. The team comes, those who are resuscitating, those who are giving, who are bagging, who are giving oxygen, who are getting the defibrillator ready and everything. Okay. Luckily, we have the defibrillator and AED, all those things here. But when it comes to management of aggressive and violent patients, you should also have a protocol for this. And when you mention a code, everybody knows what to do. All right, and we come around and help. Okay, so those are and we have the protocol that everybody recognizes. It's simple and we can all follow. All right, it's not when the patient is behaving that you are thinking, what should we do? Do this, do that. No, you should have all this done at the pre-event period. All right. Now, after this violent and aggressive incident has happened, what do we do? Do we just go ahead and just start waiting as if nothing happened? There's an incident book. How often do we use the incident report book? As for the incident report book, the nurses are doing better than the doctors. They write more than the doctors. But I believe there's an incident report book for both doctors and for nurses. I'm aware. Dr. Sami, have you ever used the incident report book? Dr. Nico? Yeah, so doctors are hardly right, but there is a book for that. You don't only for violent and aggressive. Any incident that you think it should be documented so you can look into it, take proactive remedial actions to prevent future reoccurrence. All these things should be done, right? Okay, now when there is an incident report, something happened, what is the feedback mechanism? The report system. So you were there, a patient verbally abused you or even slapped the nurse or a doctor. You reported, and that's the end. You don't know who would get back to you. You don't know which form. Okay. Then you as a health worker, it becomes difficult next time you see the patient who is behaving that way. Now you have PTSD, you run away, or you freeze, you are not able to do your job and all that. So all this will help. The reporting system with proper feedback mechanism and follow-up. I've heard of this time whereby it's not violent, but it can happen. As for the violence, I have so many examples, but here I know of someone who, I think the person was not even, should I say, attachment person, and there was an issue, and better to use their own money after the initial, to use their own money for the investigation and all that. It's difficult when it's like that. So there should be a system in place. If you are slapped or you are injured and there's a need for care and all that, well laid down protocols should be followed. It shouldn't be to the discretion of your in charge or your HOD. If your HOD is nice, if this person is not nice, then you're on your own. So these protocols should be well laid down, okay? And psychologically, is there counseling available? For me, I'm here to get any direct referral from any of the heads. Most times, it's the staff who will come to my office and say, "Doctor, this is the situation." Okay, but ideally there should be a well laid down system or protocol whereby incident reports, the management or the head of unit will look at it And I would also insist that this staff goes to see a psychiatrist or a psychologist, to help. It shouldn't be left to the discretion of the staff, right? Then for the patients or their relatives, I've mentioned some of them, they even include taking legal actions against them. Some hospitals will say, okay, they are barred from coming to this place. It happens even in football. If you invade a pitch during a football match, at least I know of UEFA and FIFA, I don't know of Ghana if you invade a pitch around but you are banned from the stadium for a particular period of time. In some places, you are barred from entering the stadium, and also there may be a monetary fine. So management can look at all this and see how it will discourage perpetrators from doing all these things. Okay. Then when it comes to the environmental factors, after the event, look at what happened that they have to dispose these patients to being violent or aggressive. Was the place overcrowded? Place very hot or comfortable? Was there some stresses? For instance, you can imagine here is not so bad, but still people still hear, me call me word. If I'm a scan. Okay, this is a very small event. So you can imagine somewhere like Confanochi. From the Golden Gate, they are asking for direction. Frustration is already setting in. Then you come to the to the emergency, and there's another issue. Already before they get there, there's frustration setting in. So all these are factors you can look at. Okay, clear direction. This is the way to the female ward, to the male ward, to the diagnostics, to the lab, to ANC, to child clinic, right? Then, of course, recognize trigger factors and all that. So, this is an example of, the next slide shows an example of, should I say signage or a poster at the entrance of the hospital in different strategic places at the hospital, telling you that this hospital is a healing environment, okay? We don't tolerate aggressive behaviors. Okay, it should be, we don't have any here. And I'm here to see that in any hospital yet in Ghana. I stand to be corrected, but something as simple as this goes a long way in reducing the incidence of violent and aggressive behaviors in the hospital, right? So now we've mentioned all the hidden metrics when it comes to how we can prevent some of these things. And because I mentioned it doesn't mean it doesn't apply to the male ward, right? Look at the male ward, for instance, the child is there, there's an entry, 2 exits, right? For 3 exits. One has been closed now. One has been closed now for physiotherapy, but there were 3 exits. Okay, and there is a camera. Now, is it overcrowded? No. But the position of where the nurses sit is not ideal. All right, it's exposed. Your trolley is accessible to everybody. Is it under lock? Your syringes are they under lock? Your cylinders are they under lock? So those are the things you can apply. So that if it's not even the patient and their relatives, they shouldn't have easy access to this. At the end of today's one, we all apply it to our different places where we work and see how. And of course, I'm here also, so you can always talk to me, all right? So now, when there's a patient who is acutely violent, what is your aim of management, all right? Is to assess the risk, okay, and keep the patient safe and achieve rapid stabilization of that patient. Sometimes you hear the patient has been sedated, no, because it was violent or aggressive, and they just pump the person with CPs and that like that too. And you come, this patient is very drowsy. And you ask why? Oh, no hard, that's the response you get. But your aim should be to, first of all, value assessment, keep the patient safe, and arrive at rapid stabilization of the patient. Don't find out why this patient is doing that in the first instance. So if you don't do that and you just quickly go ahead and give, of course, that Lagatikwa is not the main thing, but I'm sure as we are going, you all see what we should do in those situations, all right? Now, your history is very important. I added corroborative history because sometimes the patient may not be in a state to tell you certain things, but or somebody who knows the patient before, or he takes or he has some unfortunate now when they're coming, you say, how it's working, how it's dressed, and all that. I think you take in without wasting time. Well, this person is aggressive. That's not when you want to sit down and say, I'm going to spend 30 minutes. You are doing everything in tandem, simultaneously. You are taking history, you are taking corroborative history, you examine this patient, if his eyes are bloodshot, if he's smelling of alcohol, if there are multiple needle marks on his hands, and all that, okay? If this person is sweaty, is he very pale, anemic? You know, does it look emaciated? Has he lost weight and all that? These are things you can see within a twinkle of an eye. You are facing a clinical impression and having an idea of where this patient problem may be. If it's apoxia, if it's anemia, if it's substance, if it's some mental health situation, even the way the person is dressed, we call it the mental state. And the first thing in the mental state is the appearance and the behavior this patient is doing. All right, you take all these in within a very short period to help. Okay, this is the time you want to start looking for a note to be writing plenty long. You make a quick impression and you think of how to quickly arrive at stabilizing that patient. The biopsychosocial component is part of the corroborative history you are picking. Okay, this man came in unconscious. He was found in his room. He had a seizure. He lives alone. Then you are picking a history of he takes alcohol. Or you are not even sure, was he having alcohol, was he having withdrawal, was he in and he fell and he's having a subdural hematoma and now he's unconscious, he's having a seizure. These are things that has to go through your mind within that. And this example I'm giving is not a hypothetical example. This is one of the patients we saw this. Yes. So the person can come in and you have to do all this within a few minutes. Even whether he lives alone, who was there, who saw what. Within some few seconds, you should be able to pick all these and institute the appropriate thing. And this will also guide you what you are going to investigate. Because you can't investigate everything. Are you going to do a urine toxicology screening, or you are going to do HIV screening? You are going to do HP. You are going to look at the kidney or the liver, or you have to do a CT scan. So you see that information within maximum within 2 or 3 minutes, you should have a clinical plan in your head of how you are going to approach it. Okay. So history, corroborative history, physical examination. The mental state, I'll talk about the mental state. All right, being a psychiatrist, mental state is the patient state at the point you are seeing them. At the point you are seeing them. And it can alter. It can change in the next 30 minutes, 1 hour. So when the patient came, document their mental state. Then if it changes, please document. If you don't document, it's going to be difficult to know what really happened. Right? So when it comes to mental state, appearance, person well dressed, is not like we are in this room now, we are all looking good, everybody is those in scrubs and in scrubs, those wearing nice shirts and all that. So appearance, how is this person? Is it dressed appropriately? So even though we are all listening, if you came here and you're wearing a wedding gown, I will know, even though the wedding gown may be appropriate in the church where you are getting married, but it will be appropriate here. So appearance, are they kept? Are they neat? Is there a level of personal hygiene? All this to give you an idea of what's going on in this person's life. Okay. Then the behavior, are they agitated? Are they fidgeting? Are there some mannerism or stereotyping? All those things would give you an idea, right? And the speech. How is this person's speech? Is it mumbling? Is it pressured? Okay, how is the tone and all that? These are things we use to assess the person's mental state. Is the mood, is it elated, shouting on top of their voice or smiling, happy, as if they won gold or they have all the gold in the world, they are very happy, disinhibited and all that, disruptive. Their mood will tell you, you don't have to answer it, but you can observe, all right, based on what you are seeing. Of course, the affect is the objective assessment of these persons would look at their face and how are they anxious, are they depressed, or is it normal, or is it restrictive and all that. That will give an idea. Okay, perceptual abnormalities. Are they hearing voices nobody else can hear? If this person cannot communicate with you, you see him as if he's responding to somebody he's talking to and all that, you can infer that he's probably having auditory hallucinations, or is training his ear to hear what somebody is saying, does not say, okay, Martin, and he gives that response. You know that he's probably having auditory hallucinations. Or it could even be a command hallucination. So those things are all things you look at during the mental state and will guide you. So apart from the perception, the thoughts, of course, may be difficult to, but sometimes it can, if the person is verbalized and talking and is in a good direction, you can actually be able to assess the thoughts, okay? The ones you can assess indicate that because of these patient states, I was not able to complete the mental state, and you come back and do what? And we assess the patient, okay? Are they aware of what's going on? Are they aware of their situation and all that? There's a way we do the assessment, but I don't want to bore you because I don't think anyone is a psychiatric resident here, but there's a way we assess insight, okay? Now, judgment, and for the ER, we also do a risk assessment. Mention how you do some of the risk assessment and all that. So, we've mentioned so many things concerning the non-pharmacological way of treating. We are still going to the pharmacological, but for me, paying proper attention to non-pharmacological and all those factors go a long way. All right, you heard of de-escalation. People have been saying de-escalation. I don't know if people understand the processes involved in de-escalation, but we hear a very nice English term, de-escalation. We'll look at some of the ways we can do that. So sometimes you can let the person blow off for catharsis. So let them blow off steam. Maybe after that they will calm down, kakra. All right. Then the interventions we mentioned earlier on. Then good communication skills. Okay. One person, ideally, when it happens, one person during that shift or during that event should be the one to communicate. It's better. And it's not only in the emergency setting, in every other setting, you saw the same person, the PRO, or the spokesperson for this person, or in our traditional panel, or chairman, right? He is the one that would spearhead any communication effort. So let somebody do that, okay? And assertive training, okay? You do all that. But when de-escalation fails, before you come to pharmacological, talk to them, and you see that, okay, if I want to give medications, this person is not cooperating. And orally, difficult is not mindedness. So I say that you can give iron or IV without physical restraint. It could be a leader to yourself or to others. There's a way we go about the restraint. I'll talk about it. All right. Talk about it. But if you've done all that, when you do the physical restraint, then you have to quickly move to pharmacological. You don't restrain and leave the patient. You don't restrain as a form of punishment. You restrain and quickly do your intervention. If it's the antipsychotics you are giving, ideally there is a step up approach. I will show an algorithm. So you can give it diazepam. Your mind, you should know your patient. If this man taking alcohol, if this man an elderly man, the young person, you should know so that if you are giving diazepam to an elderly man, you should know the dangers of paroxysmal agitation and all that. So if you are an elderly person, you probably start low and go very slow. These are things you look at for. So if your patient you're actually looking at, it's not a cut and paste thing for every situation. Look at your patient's situation. Some may require oxygen, some may require antibiotics, some may require blood. Okay. So benzodiazepines, lorazepam is common, the oral one is common. Yes, still parenteral lorazepam, but it's a little bit expensive. Last time I wrote for a client, I think they got a vibe for 1,002, and it has to also be refrigerated and all that. So it makes it difficult in terms of access and all that. But diazepam is easily available. Okay, midazolam is also available. So you can give your diazepam. Then you can give your antipsychotic. All right. And based on the patient history, most stabilizers, right? Most like lithium, carbamazepine, sodium valve. Sodium valproate, if you are giving sodium valve, you have to be, in fact, for any female of reproductive age, avoid sodium valproate, okay? Lamotrigine also is also a mood stabilizer. Then, based on the patient's history, like we said, antidepressant also may be required based on their or anxiolytics. Okay, so it's your patient that will determine what you are doing, right? Now, we've been hearing de-escalation, de-escalation. I decided to put this slide so that we'll have an idea of how this is done. And you have to practice it. There are so many, should I say, materials online, okay, on YouTube. If you don't want to go to the formal de-escalation training, there are so many materials online. You look at reputable sources, and you can have a look at it, how you read the tone of voice and everything. Because when it comes to communication, you that I'm coming to harm you. So how you do it, how the tone of voice you use when you are talking to the patient and all that. All that, scissors, tourniquet, and tourniquet. Even the tie you are wearing, the necktie you are wearing, will be a source of weapon. So I hardly wear neckties now, right? Even your necktie could be a source of weapon, right? So accept the environment. And any verbal threat, don't disregard it. Don't disregard it. Then don't crowd the patient. So overcrowding can push someone to violence or aggression. Now this person is probably agitated or anxious. This is a new environment. He's here. All of you are straight faces. Some are wearing white. Some are is agitated. And you don't crowd the patient. Move some feet away from the patient. Okay, and make sure you clear the area of other patients. Or those patients are in your care. The ones that are already on admission. And you're okay. Okay, then you calm. You have to be confident. That's not when you should be threatening. So it's the trick you have to learn. And be sure that the patient who is very aggressive, speaking and doing more than that, and you talk to them. So your total mastery, you should be confident about it. Experiencing fear and anxiety, right? To become measured. It's the memory for how you want to start yes, SAV. When you want to start your studies, you don't really know how to do that. So you can offer support, okay, support to the patient. So those are the moments, okay, acknowledge what they are going through, okay, invalidate their concerns, okay, and then the patient will know, okay, not that you don't regard whatever I'm going through. So if I was in that situation, I'm sure I would do the same, but they are here to help you, right? They are all here to. Can you tell us what the concerns are and everything? And you'll be sure the patient will, most time it may happen in the work, right? They will say, oh, I probably never know back you know, so it happens. So you should learn the de-escalation techniques, and you don't argue amongst yourself in the presence of the patient. Even if one team member is saying something that you disagree with, or you have an alternative opinion or suggestion, you don't do that in the presence of that patient or their relatives. All right? You could just go ahead and you say, can you excuse me? Then you quickly talk to that person, your consent, but not in front of the patient or their relatives. Okay, now, if you want to apply physical restraint, okay, some say at least 4. Okay, but you should be trained people. But if you really want to do it, you need 6 people who are trained in physical restraint. Okay, and the aim is you want to restrain all the extremities. That's the upper limb, 1, 2, 3, 4, lower limb, right? And the head. Okay, you do that, and the 6th person would apply the restraint and any medication you want to give. So the arm 1 person, the other arm 1 person, the lower limb 1 person, and someone holds the head straight. Okay, and the patient should be supine, not prone. Okay, now when you've applied the restraint material to their things you have to look out for. Don't use, most times gauze we use. And this patient is agitated and you use gauze. Then it becomes very thin and the gauze becomes a tourniquet and cuts deep into the flesh of the patient. Cellulitis. In fact, in some instances, you can even have amputation later on. Gangrenous, and you have to amputate and all that. That's another recipe for medical legal reasons and all that. So there's a safe way to restrain the patient. There is a safe way. If I will mention some of the indications, some of the things we should do and we shouldn't do. And when you restrain, there should be an order. Like you're prescribing medications. Give this BD for 2 days or that. The same thing with restraint. Restrain this person for the next 15 minutes until you achieve this. If the 15 minutes passes and the person is still not achieve stabilization using the benzodiazepines and the antipsychotics and stabilizers, you do what? You write another order. Then while the person is restrained, you are continuously monitoring the person. Okay, you don't put a pillow behind the patient's head and say you are restraining. You can actually suffocate, right? When you're also restraining, the person holding the head should not, most are wear gloves, right? Should not put the glove hand to cover the nose or the mouth. You can cause asphyxia and all that, right? So if the patient is even spitting, for instance, is spitting, somebody can be very aggressive, they spit and all that. You're better off putting an oxygen nose mask, okay, oxygen delivery, set the mask into the face. At least that one you can also give you oxygen while and if it's spitting, it's not going to hit you, all right? Then you incline the bed at 30 degrees. Don't put a pillow. The pillow can actually suffocate the patient. Incline the bed at 30 degrees. Then also, when you apply the restraint, don't tie it to the rails of the bed. Tie it to the frame of the bed, the frame itself, right? Now, when it comes to the material that you are using for restraint, is this a clinic, a hospital? So there are standards. There shouldn't be a material that will hurt the patient or cut the patient. So most times, the restraint, you see, it has padded foam inside, so it won't hurt the patient. So Angie and my ER and other staff, after this, you are going to write the position to management to get you proper hospital grade restraint. Okay, and you look at the numbers you want. Okay, then after this being done, what happens? You give your medications. Okay, now sometimes they may be so agitated that you will say, oh, let's restrain, then we'll give IV. No, you can give iron. When this patient is a little bit calm, you can now set the IV line and give other IV medications you want to give. All right. Now, when you are giving those medications, your aim is not to sedate the person. All right. If you think this person needs antipsychotic, give antipsychotic. If you think this person needs sedation, give something for sedation. Don't give CPZ, chlorpromazine, that's like that because you want to sedate. CPZ is a third generation antipsychotic with own issues when you give, so, doctor, you never saw that, you give like that. Why don't you give diazepam or lorazepam? And don't be afraid. I remember when I was at Accra Psychiatry Hospital during my residency, and there was one evening I had a call from the clinical care coordinator. Oh, doc, there's this patient at this one of the ministries very close to the hospital. Is destroying everything and everything. And it was me they called to go and bring him to Accra side. So I called the driver, two nurses, and myself, and we went. When you ask for help when you go to the ministry, when you hold the person down, we give an IM medication, not IV. Not when you want to start looking for line. You can give the IM, it's calm a little bit, all right? Then you can set the line. But when you put it in the vehicle, that alone calm him down enough for him to say, okay, I'm going to agree to the treatment I'm giving. It was a non-psychiatrist who reported, all right? So he agreed. So we didn't need to go ahead and give something to make him sleep and knock him off. Sometimes people are so sedated that they actually urinate on themselves because they are sleeping. There's no electrical catheter in, and you've knocked them out, and they just. There should be dignity in all this. We are looking at some of the ethical considerations. There should be dignity in how we do these things, right? So we did that, and if you have up to 6 people, 5, or even not 4, the key is you should be trained in doing this thing. Not that you just assume, say, I'm doing what I want to do. And that thing whereby they tie 2 fingers, it's torture. That's not how you do restraint. Please, you shouldn't do those things. And your gauze bandage or something, that gauze thing is not your restraint material. Neither is your tourniquet, the IVDB set, those plastic rubber that you tie, that's not your tourniquet, and that's not your restraint material. Please, I beg you. I took time to talk about these are practical things we do, and when we get this one, it will make this afternoon webinar worthwhile. So this is a picture of someone on a trolley stretcher, right? Can be on a bed. So this is a 4-point restraint. There's also a 5-point restraint, all right? So what you do is the upper and the lower limb. Let me get the. Oh, go back. The lower limb, you have. I have to get the pointer. Yeah. Right click. No, come here. Right click. Right click. Then pointer options. Yeah. Laser pointer. Yeah. So go back. So see the lower limb, there is a restraint here. Okay. Now the upper limb, one is up, another limb is down, right? And the head is raised at 30 degrees. Okay. You don't put a pillow here. Most beds, except I don't know where you were, most beds you can adjust it to the angle you want. And you strap it to the frame of the bed, not the railings or guides. Okay, you don't put it here, it can injure the patient. You strap it to the frame of the bed or trolley. That way, you are doing the right thing. This patient is lying supine. If you do it prone, you can aspirate. You put a pillow where the head is, you can also duplicate. Now, when you are trying to restrain this patient, the patient may turn face down, that's prone. Don't apply pressure, especially when you are trying to keep the head steady. But most times, your hand may be on the neck. As you are doing that, this patient can asphyxiate. There was a gentleman who was in the US, I think a couple of years now, that the police were trying to restrain him, and somebody put the the knee on the neck, and he died. Yes, Floyd, he died. So don't put any pressure on the neck. Don't restrain while the patient is prone. It should be supine. And when you've done all this, check every 15 minutes. You are monitoring the vitals and everything. You don't restrain and go and leave. You are restraining to allow the patient to give you space to intervene. So you give your medication and all that. You expect your medications to start working. You should know the half-life of some of these things. So after a particular period, this restraint should go off. You can't have someone in restraint for forever or as punishment. Now, this has both legal implications and ethical implications. I'll mention the ethical implications. For the legal ones, I'll only mention that in Ghana, we have the Mental Health Act, okay, H4 to 2012, and the LI, in 2, 3, I'll get there, that regulates how we conduct these things, okay? So we'll go ahead. So this is how you actually restrain a person using a 4-point or a 5-point. The 5-point will cover the pelvis area. Okay, there's a strap that will go here and so that they won't be pelvic thrust and all that. That's the 5th one. But usually it's the 4-point, but you can also go for the 5-point physical restraint. Okay. Now, something you should do. Use 4 or 5 points. I think I mentioned that. Use medical grade restraint. Like mention the characteristics of some of these grades. Supine position as much as possible. Restrain one arm above and one below. We've mentioned all this. Elevate the head to 30 degrees and tie the restraint to the bedroom and not to the rest. We've mentioned all this. Don't restrain in a prone position. Airway complications. We've mentioned it. Don't restrain to the bed with the risk of injuries. Don't do this 2-point restraint whereby it won't help. Don't tie the knot in such a way that when you want to remove, it's so difficult, you have to look for a scissors to cut. Sometimes there's no space, it's so tight, you have to really use a surgical blade to rather cut off the gauze bandage or whatever they are using. And don't put a pillow under the patient's head, okay? I think I've mentioned most of the things on the general tenets of the including bells and all that, so we won't talk much about it again. The next step, of course, the medical treatment, which is also another interesting part. There's an algorithm whereby you can follow the. I think we've mentioned this in the history and all that, so you don't have to spend so much time. But if the patient is, for instance, if it's delirium, is it pneumonia that is making it delirious? Okay, is it anemia? Is it bronchopneumonia? Is it complications of surgery? All this, you address the main factor, and in the meantime, you can give either low dose diazepam or Adol 5 milligrams, and the patient most times they will come. Then you address whatever that could be causing the situation. If it's withdrawal, you should know what you should how you go about it and all that. Right? So these are the drugs we talked about them extensively, so I won't mention them again. Sometimes you may have to combine both benzodiazepine and maybe an antipsychotic. All right. But like I said, the aim is not to knock this person off to sleep. The aim is to control the agitation, intervene, look for the causes, and not to make the person sleep the whole day to the extent that you can't even stand up to tell you want to boil or something like that. All right. So ethical considerations. Now, ethical consideration has to do with professionals. What is allowed in our job, right? And we have the legal consideration that has to do with the law. So there are two different things. Okay. Now, when it comes to ethical considerations, first thing is do no harm. All right. Okay. Non-malfeasance. That's the first principle of ethics. Non-malfeasance. Then beneficence. Now, whatever you do for the patient is good. Okay. Then justice. Right? Whether it is distributive or what? Procedural. Procedural is how did you go about what you are doing. There should be justice in it, right? And autonomy is the fourth ethical principle. Now, the autonomy, if this patient is not in a situation to tell you, oh, I don't want this, or that state of mind is a danger to himself or to another person, okay, then that's where the legal considerations come in, right? Our Ghana has a Mental Act, Health Act 846 that was done in 2012, and the legislative instrument, okay, 2385, this was done in 2019. There are a lot of guidelines on what to do when this patient is an involuntary patient. There's what to do when this patient needs seclusion or restraint. What should you do at this point? What should you do for how long? The intervals, how long should this person be on restraint? How long should you be checking on the patient? You don't put the patient on restraint or a patient on restraint and seclusion at the same time. Okay. And if the person is on restraint, how often should you check the vital, check on this patient? And if I think it's every 15 minutes. So you can have a look at the LI 2385, Ghana's own. That one will give you all that one is the whole topic on its own. But it's good at putting there, you look at the bigger considerations, okay? The Mental Health Act also, then you look at it. So the ethical principles, whereby when it comes to autonomy, the patient says, I don't want, but you want to admit this patient, involuntary patient, there is also clear guideline on the LI on what to do and all that, all right? Now, whatever you do, you use what we call least restrictive alternatives. If this man can take per oral, no rush and go and give parenteral. If you can de-escalate, don't rush and go and restrain him or give him some. So some even say chemical tranquilization or sedation. Don't do that. So you have to control the aggression and intervene to help the patient. Okay, so these are the ethical considerations and the legal considerations. Then when you have these guiding principles of management, you'll be happy with yourself. Because you are doing the right thing for the patient, and ethically and professionally, you feel fulfilled. All right. So I think these are some indications that what I did for seclusion and restraint. I took this snapshot from Sadoc's and Capos, one of our textbooks. Okay, so if you want to prevent clear and harm to the patient, I think we mentioned all this, or prevent this significant disruption of treatment program, or assist in part of ongoing behavioral therapy. Sometimes the patient can even tell you, some of them will tell you they have the whole signature, they have an idea of what happens to them. And what I'm saying, just last week, somebody, I was called around 2:33, luckily I was still around. That's a Madam Yaba is coming. So we quickly gave her some medication she took orally. We didn't have to restrain her or anything. So sometimes they can be aware of their situation and they know the signature figures and they tell you. So listen to them. Don't be in a rush to do all those things. Now, if the person is extremely unstable, you have to find out the underlying reason and deal with it. Okay. If a patient is delirious, like you mentioned earlier, deal with all that. Okay. If the patient is having severe drug reaction, but you don't go and keep this person in the room, nobody, because you can't monitor, or you should release the person. No. So these are things you have to look at. All right. Then we've mentioned all this. So I think we've mentioned also that it should be done in a dignified method. We've mentioned all this restrictive method and all that. Won't labor this so much. So in conclusion, I think violence and aggressive behavior by patient relatives and friends that commonly occurring at the hospital. Our knowledge of this and being competent in risk assessment, early identification and management will greatly reduce the impact and hopefully the frequency of these events. And a written workplace policy, if I should have put the written in capital, a written workplace policy document should give clarity so I can have a decision making when you are faced with this situation. I thank you so much for your time. Here are some of my references and it's never okay to accept aggression or violence in the workplace. Let's do the right thing about it. Thank you. There are questions and all that, comments, suggestions. I'll be very happy to take them. Thank you very much.
Please let's put time together. All right, thank you so much, boss, for such an insightful presentation. I think at this juncture, we'll just make room for questions. So for those online, you can please send your questions in the chat box, both on Zoom and YouTube, and we'll read it out to the resource personnel. Those in-house, you can ask your questions now. I'm sure we all have a lot of questions. We don't want to waste so much time, so. Questions, suggestions, no. Please, for those asking about the CPD, we've posted the link in the chat box, so you can fill it and make the necessary payments there. The presentation will be sent to only those who have paid for the CPD, unfortunately. So if you're not paying for the CPD, we cannot send the presentation to you. So please, questions. It's in-house, any questions?
Okay. How to manage it? Yes.
So if there's a code there, I think it will guide all of us. Like it wouldn't be like some people are supposed to do the person. Get the medication. Sometimes, honestly, in my experience, sometimes the doctor doing me up closer to the patient. I don't know why.
I think the same applies for the nurses. Everybody, it's not just the doctor.
Yes.
But then they are somewhere waiting for you to go the person back. So if they are protocols, so that we all we are all professionals in doing it. And then the first time, the patient, and then also go far as someone with the law, then the ethics too.
Okay. Very good question. Okay. So first of all, when we say train, it means all staff, not some dedicated group of staff when they're aggressive patient or valuable they come in. No, because it can happen at any point, from theater recovery to ONG when they just delivered, or when they are being pregnant, to male or female ward, just be delirious and status change, emergency, even trial OPD. Okay, sometimes even at the entrance of the hospital. I'm happy one of our orderlies is here. Sometimes they will even the first people to even see the patient that somebody is behaving and all that. So the security staff, the orderlies, the nurses, doctors, even sometimes the records. Or sometimes if you're all trained and they need, they only need 6 out of the majority, or 4 or 5 out of the majority. So the training is for all of it. It's not that there's some specific designated people who that when there's violence or aggression, they will come and know. Now, you mentioned that sometimes there's an aggressive patient or violent patient on the ward. The doctor is called, he comes in, and it's the nurse's job to hold the patient down while he writes the medication. But I think from that vignette you just giving me, first of all, each word there should be an emergency tray. Okay, that is not when you are writing prescription. In the emergency tray, I'm sure there are some medications that we know we should have. Those should always be available. The key challenge we've all noticed in most hospitals is that you fill the tray, we don't replace them after using. Then the next time there's an emergency, those vials are not available, those medications are not available. And at that point, we are writing. So let's inculcate the habit whereby the emergency tray system, we refill them when we just use made use of the vials in it. That one we use the whereby the doctor is coming and it's just prescribing. Okay. Now, I said it's a team where you need 4 to 6 people. So everybody is involved. So when we were talking about the proper restraint, say one on each leg, one holds the head, and one applies the restraint and the medication. Most times, the doctor who is the team leader that should be the 6th person. So after you've restrained, he's applied the restraint, secured it to the bed frame. He wants to give IM diazepam because probably the patient is that they can't set a line. He applies he administers the IM diazepam. When he's a little bit calm, he set the line and give any other medication. It should be available on that trolley. Luckily, we have emergency trolleys that have lock here. But as to the procedural whereby we don't replenish the stocks and all those things, we should work on that. I hope that happens. And please, doctors, don't stay 20 kilometers away from the patient when they are called. Okay, you are the team leader. You should exhibit competence and confidence, inspire confidence in your team members. All right, you usually be 20 kilometers away and say, you don't do that. You don't inspire confidence. You don't boost morale when you do that. So you should be competent enough. And I hope after this program, those things will not be happening. Now, with the protocols, I plead with, because we have people online, each facility should have their own protocols developed. Most times you do that in conjunction with your clinical care coordinators. Protocols are approved for the particular center you are. So you can't just go and write something and say you are doing that. There's a process to go through that, okay? So get in touch with your clinical care coordinator. If you have an emergency physician or a psychiatrist or any physician or specialist that is available in the facility, in conjunction with the clinical care coordinator, sit down, look at your peculiar needs, okay, and draw up a protocol that is acceptable, okay, that will work for your place. Here, we also look at that. Okay, there are so many protocols on the emergency board. I don't know if those, I don't see most of those protocols everywhere, but mostly at the emergency, you see them there. So if you have to copy and send them to the other department to look at it. Most times, from experience, what happens is, in an emergency patient, they call me. Basically, that's what happens here. They call me, if I'm not at post, maybe 1 hour, they will call me on the phone. I'll give what advice I would give. Sometimes too, I think the last one I had was from ONG. Is anyone from ONG here? They called me at night, oh, this patient had this history of mental health issues, plenty of, but currently the patient is not having it. So they are anticipating, okay, what should they do if it happens? And I told the house officer that, please, this patient is currently not having any psychotic episode. It's good you know the history and everything, but don't assume because that's a mental health issue. Automatically, this patient is going to be violent. But in case this patient mental status changes, we can give this and this and that, right? So, but I think everybody having the protocol on each ward would help. It doesn't mean because there's a protocol, you won't still seek help if you are not so sure of what to do. It's a dynamic process. Patients are different. Okay, you may give someone diazepam 2.5 or 5 milligram and they start having issues. Okay, so you can always still feel free to call a senior colleague, but we should make sure that we have those protocols at our different places of work. Any more?
All right, so from the Zoom, we have a few questions. Is it right to assess and manage a client who is in a handcuff or rope restraint that has been brought to the facility?
Okay, that's a very good question.
Would you want to speak into
Yes.
it now? I should
No,
read
no,
it.
let me speak into it. Because that's a very, very good question. So most times, patients who have gone through the legal system, they are brought by the police or detective. Sometimes they've not even gone through the legal system. The case is just starting, they are under detained, they've not yet gone to court. Sometimes they are in court and the judge asks for a mental assessment or a psychiatric assessment. So they come in with handcuffs. Now, per our LI, the Mental Health Authority legislative instrument, there's a component that deals with that. When they come in with handcuffs, when they get to the hospital, please remove the handcuffs. Don't treat a patient while he's in cuffs or he's in a rope. Okay. In fact, it's actually a statement in the LI 2385 of 2019 for Ghana. Okay. So that's a very good question. The straight answer is no. He wasn't violent. It's a criminal or legal issue. It comes in. Ideally, in fact, the policeman should be outside the ward, not even on the ward, so that the patient can, if you are suspecting the patient may abscond or something, you can be conscious, but even the policeman should be outside the ward, not where the patient is. You shouldn't treat the patient with handcuffs on, please, or any rope or any restraint. Thank you. My doctor here is wondering.
So, in practice, I mean, when I was doing my surgery at Confanochi, when they usually bring them for hernia, they are in cuffs throughout their stay.
Which is wrong. So
is it that the security, whoever brings them is not aware, or we are not aware and they are having their way? Because
so I'm happy we are having this discussion. Okay. Now, before 2012, we didn't have any mental health act. My teachers, Professor Osei and Dr. Uswentri and all, they've been working so hard. In 2020, we were able to pass the Mental Health Act 846. And I'm proud to be a psychiatrist because we've done so much work that we've sort of codified some of these things. It's now a legal document, right? And in 2019, we're able to get the LI, that is how we go about our work. Okay. If you permit me, I could actually open the LI and read the statement from that chapter on restraints and handcuffs when they come in. Permit me to just go through and pick the.
So whilst our resource personnel is trying to help us with the material, we can still send our questions.
Okay, so a patient shall not be restrained in handcuffs, chains, shackles, ropes, locks, or with an item in a matter that is likely to cause bruises or damage to the body of the patient. All right. The head of the mental health facility shall ensure that a record is made of the situation and restraint of a person as prescribed in Form 4. That's another thing that has to do with. But that statement is a standalone statement in the LI. Okay. You may not know. So from 2019, if you've not been abreast with the mental health space, the advances we've made, this is an opportunity for us to keep abreast with those things. Okay. And these documents are available in the public domain. So we can Google them and have them and read through it. Okay, it's actually a statement. All right, Dr. Bwaji.
Yeah, I mean, thank you so much. I think we're not privy to this So now that we would go with that information. So thank you once again. There's another question from Dr. Roxanne. Are aggressive patients to be managed at the clinic or only the psychiatry department?
Okay, Dr. Roxy. So you are looking at an aggressive patient. The first thing is you assess, why is this man aggressive? So if someone is having delirium and is aggressive, you treat the underlying cause. It's a reversible cause, or it's potentially life-threatening. So in men, you pick the diagnosis and you treat the underlying cause. For the acute behavioral testing, then you continue the definite management. You don't have to refer that patient to a psychiatric place, except maybe it is a psychiatric condition. You came to your facility and you did the initial management of the acutely agitated patient. And when the patient is a little bit stable, you make recommendations or arrangements for referral to the place where patient will get definitely treatment. But someone who is who had hip surgery and is now delirious, and you've been able to identify it, you managed it, you don't have to refer to a psychiatric defense. So the underlying condition will determine whether you end up referring that patient to a psychiatric condition or to a psychiatric facility or not. All right.
All right. Thank you so much, Dr. Gundipe. There's another question from Joshua Aqua. It reads, please, can the police be involved in the hospital? Sorry, can the police be involved if the hospital security is not enough? And can an aggressive patient be referred to a tertiary facility?
Okay, so the first part of that question, thank you, Joshua. Dr. Joshua, I don't know if you're a doctor, but I think I know it's Joshua Aqua. If it's the same person, I'll salute you. So normally during the protocol, when you call for help, like there's a code, so your staff, your local security, and police, ideally you should have the police emergency number, all right? Some instances you need to call the police, and I'll give the Sweba example, the 2013-2012 Sweba baby case. The community came disrupting, destroying properties and beating up doctors and nurses. We had security personnel in Provatochi, but they were not able to handle the situation. So a call was made to the regional command, police command, and the enforcement was made. I think after that incident, it wasn't long. Right now, even at CAT, there is a police station near the A&E car park. Okay, but it's not every center that will have a police station in there. So normally there should be a security coordinator in the hospital. And if they can't handle it, either the administrator or the security coordinator can call for help by the police. So it's a standard practice. It's standard practice. All right. I hope that answers your question, Joshua Aqua.
All right. There's another question from Johnny Walker. Pache. Please, any special consideration for aggressive patients in any stage of gestational age?
I'm not sure of the gestational age, but when you talk of different age strata, okay, I've seen, so aggression can occur in any age, okay, even seizures, the child can have behavioral manifestations or aggressive manifestations, seizures. Okay, I have one that comes to mind readily is a young boy who had a head injury, RTA, and he was very aggressive, physically aggressive. He was on the ward, becoming, take the mom's phone and smash it against the mother and all that. So it can happen at any age. Of course, we assess and we give the medications. In old age, to geriatric age group, you have to be careful. Their metabolism is different. So the general rule of thumb, if you don't want to err, is you go very low dose, and you go very slow. Okay, and so for instance, one particular thing is something like benzodiazepine for elderly people. If you can even avoid it because of the danger of paradoxical agitation. So you may even avoid it in elderly people. You may give maybe low dose of a second generation antipsychotic, okay, like olanzapine. Bearing in mind that as they are old, they may have other metabolic condition and everything. So you look at it, oh, Haldol is still safe. Low dose Haldol is safe, 2.5 to 5 milligram. Okay, and you correct whatever background comorbidity they may have. Okay, so that's generally the rule when it comes to aggression. When it comes to kids too, of course, you look at their body weight, and for kids, most time we give them risperidone, 1 milligram and all that. It helps also. Okay, so those are the consideration when it comes to different age. I'm not sure of the gestational, but when it comes to different age strata or categories, that's the general rule of thumb. Okay.
All right, thank you so much. I believe we're all learning a lot. And right, another question from Wisdom. Do you mean, okay, I think we can skip that. Please, do you have any PDF of the main document that contains the Mental Health Act 846 that you can share? I think for the sharing, we are limiting it to those who are paying for the CP, unfortunately.
But these are documents, they open domain.
Yeah, they actually, you can just Google it and
yes,
you can always find it. It's open to all. Right. A question from Isaac. So I think it's inference from the handcuff stuff.
Okay.
So is it must the handcuff be removed before you care for someone who has stabbed 3 people or an armed robber who was brought to your hospital for treatment?
Okay. So now, the reason why that patient stabbed 3 people, you want to find out why. Was it an instrumental aggression or as a result of a mental health issue? You know, so you have to look at all this. You look at the patient's situation, but for doctor, we don't treat in handcuffs. If there has to be restraint, follow the protocol we just identified today. Okay, not handcuffs. I don't know what holds true in the police hospital. I don't know if they treat people in handcuffs at the police hospital. I know some of I don't know if any of my bosses who are in the police are here online, but for doctors, we don't treat in handcuffs. If the patient is a danger to themselves or to others, there are laid down procedures. Okay, if there's this concept of duty to warn and duty to protect. That's types of 1 and 2 is stem from whereby somebody threatened to kill someone and confidentiality was maintained, and the gentleman went ahead and killed Tatiana Tarasov, and it became, so there was a judgment, and we arrived at this duty to warn, duty to protect. At that point, if the reason why the armed robber was brought to the hospital, why was he having an injury? Did they beat him to a pulp and he has laceration and you are coming to suture? If you want to suture, you should do it in a human situation. You're a doctor. You are not a butcher. So if you want to suture, you have to use your analgesics and light sedation, you know, your light Novocaine and everything. And you suture. You don't say because you're an armed robber, you suture without giving any form of anesthesia. No, so we have ethical reasons how we work, and the handcuff, you have to find out why is in a handcuff. If it's a legal issue and it's not mental health issue, in the hospital you have your protocols you have to use. You have to know the handcuffs, and I think I read the chapter on that in the LI 2385. You don't treat it in handcuffs and all that. If it's having a mental issue too, there's a process where you go through and how you follow all that. Okay, that's the LI. So I think in a nutshell, you don't treat someone in handcuffs. If it's a danger to himself, look at the procedures we've highlighted today in this webinar and follow those procedures. Thank you.
Thank you so much, Dr. Ogundipe. I think this presentation has been really insightful. I believe we should be having more of these discussions, even if not quarterly, quite often, so we can all be abreast with the various updates. And now with the issue of mental health, I think the awareness is global. So we are all now coming to the realization that we really need to invest in mental health. So I want to say thank you. Just before we round up, I want to make room for, I think, just a few questions. That's in-house. Do we have any questions? If not, I'll ask questions. And I think we have a few number here. So want to make, I think our in charge has already asked a question. We have a few people remaining. If not, I'll ask questions before we leave. But before we do that, there's a question. So I think there's a bit of clarification from Johnny. It says, respectfully, so clarification on the gestational age with respect to the sizes. Precise approach for aggressive patients in any stage of sizes. I think this will be quite lengthy.
Okay. Is the one? Okay.
No, it's
So why is this patient aggressive? That's the first question you want to ask. So if you don't assess very well, the approach is not to just jump to, oh, let me give haloperidol, or let me give diazepam. Okay. If it's anemia, if it's preeclampsia, you will deal with that. There may be a behavioral component. A woman who is pregnant and decides to have, unfortunately has a stroke and has behavioral component, or is pregnant, has an RTA, has seizures with behavioral component and all that. So the clinical context will determine exactly what you are going to do. Okay. In some instances whereby, depending on how the clinical situation is, and it's very early, and you look at the risk to either the mother or to the fetus, that will determine what. And most time when you see this, it's actually a interdisciplinary approach whereby the obstetrician is there, the psychiatrist is there, and we will deliberate on what's the best outcome for this patient. What should we do? So it's a hypothetical question, but when it comes to patient management, it's a little bit specific. Okay, if it's UTI, renal kidney problems, or kidney problems that is not having uremic care and all that, that will determine the management approach. So what the patient presents will determine what we actually do. The Haldor or whatever we are giving will not take away the predisposing conditions that made that woman prone to being aggressive. Sometimes it could just be a woman who has a previous history of bipolar affective disorder and is now pregnant and is having a relapse, or she didn't take her medication or all that. That also will determine what we are going to do concerning our management approach. I hope that answers your concern or question.
all right. Thank you so much, Dr. Bernard Ogundipe. Right. So any more questions, please? No questions. So I think we would end the webinar for today. If there are no questions, I think we would want to end the webinar. I want to say thank you to all who were able to join this discussion. I mean, those in person and those online as well. This meeting couldn't have been a success without you being here. So we want to say thank you so much. And we look forward to organizing more of these talks going forward, so we can be well informed on the rules of the land when it comes to health regulations, mental health regulations, and its cohorts. So once again, thank you so much. Just a quick announcement. So for those interested in registering for the CPD, the links have been posted in the chat.
the lanes have been, so you just have to fill the spreadsheet and you'll be contacted as to how to go about the payments and all. And the presentation is actually going to be sent to only those who are making payment for the CPD, unfortunately. So once again, I want to say thank you for your time, and we look forward to seeing you in the near future. A pleasant day to everyone. God bless. Bye.
Maybe you were.